Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Disparities in Overdoses and Access to Medications for Opioid Use Disorder. And our presenter is Dr. Kelly Ramsey, Chief of Medical Services for New York State OASAS. She'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment profession. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Ramsey.
Thanks so much, Dean. Let's start with our learning objectives for today. Discuss the epidemiology of substance use disorder in the United States historically and currently, including the disparities in overdose rates between different racial and ethnic groups. Discuss the historical and current legal framework regarding substance use in the United States, which has been grounded in racism. Discuss incarceration in the US historically and currently. Discuss the current opioid epidemic and opioid use disorder in the United States, including treatment disparities. And finally, discuss institutional and structural racism, historical trauma, and stigma. So first, a couple quotes as food for thought as you're listening to the presentation. Any strategy that doesn't see people of color as essential to the fight also guarantees that even when there is a win, people of color continue to lose. Unknown. The notion of a drug-free society is a political statement and not one that's grounded in reality. And that's from Carl Hart, PhD, who is a professor at Columbia University. First, let's discuss the epidemiology of substance use disorder in the US historically and currently, including disparities in overdose rates. So here are some historical images of white women under the influence of opioids. We don't have time to go in depth into the prior opioid epidemic in the 1800s, but these images show that amongst individuals using opioids at that time, many of them were using patent or over-the-counter medications that contained heroin and or cocaine. And often these were targeted towards upper middle class and upper class white women. These show additional images of upper class and upper middle class white women injecting opioids. So this slide has some historical depictions of substance use disorder, substances, and persons with SUD. So going from left to right, on the left-hand side, this came from NPR, and this was looking at the prevalence of the term addicted in American English. Again, we prefer not to use that term today. We would prefer to use the terms a person with a substance use disorder, but this is demonstrating the use of the word addicted from 1815 to 2005. So as you can see, in the 1800s, there was still a significant amount of substance use disorder. The part where it is lowest in the graph is the time period in about the first third or half of the United States history on this chart, showing the first half starting in the 1900s. And that is the time when we see a lot of the formation of drug laws, and we see prohibition as well. And so it's interesting to note that time period shows the least amount of substance use in the US. If we look at the next pictures in the middle, those are advertisements of some of those patent over-the-counter medications that I mentioned, that contain cocaine and heroin. So on the top, you can see these are cocaine toothache drops, and these were intended to give to children to help with tooth pain. On the bottom, you can see is the Bayer company, which now we know for making aspirin, and this was one of their patented products that included heroin. On the right-hand side, we see some images historically of individuals using opium, which was the primary form of use of opioids at that time. On the top slide, you see images of Chinese Americans, and on the bottom, these were folks, I'm not sure what state this is from, but it was somewhere in the Western United States. So just a reminder of the historical view of substance use disorder. In 1785, Dr. Benjamin Rush published his book entitled Inquiry into the Effects of Ardent Spirits upon the Human Body and Mind. So this was a book about what we would now call alcohol use disorder. And in that book, he saw alcohol use disorder as a disease that required treatment and recommended setting up special hospitals, what he termed sober houses, to do so. Of alcohol use disorder, Dr. Rush said, the use of strong drink is at first due to free agency, and from habit it takes place, and from necessity. This is a very good depiction very early on of an understanding that to meet a diagnosis of a substance use disorder, it involves a compulsion to use over which that individual does not have control. And he seemed to have a preliminary understanding of that concept. So substance use disorder was viewed differently historically. In the early 1900s, heroin was seen as a potential solution to the problem of morphine addiction. And there was the philanthropic St. James Society that mounted a campaign to mail free heroin samples to persons with a morphine addiction. However, the Harrison Act of 1914 regulated and taxed the production, importation, and distribution of the aforementioned opiate and cocaine over-the-counter patent products. In Supreme Court cases, United States versus Doremus and Webb et al. Versus United States, so two separate cases, in March of 1919, the court upheld the constitutionality of the Harrison Act and ruled that a physician might not write prescriptions for a person with substance use disorder, quote, to keep him comfortable by maintaining his customary use, unquote, essentially making it illegal for physicians to prescribe medications that would control the symptoms of withdrawal and cravings for an individual with an opioid use disorder. Exceptions were later made in the 1970s for the legalization of methadone for the treatment of opioid use disorder, and later in the early 2000s, the exception of buprenorphine to treat opioid use disorder. During the time of Prohibition, substance use disorder was recategorized from a medical condition to a, quote, moral depravity, unquote. So again, that framed things very differently for people. Laws were enforced unevenly with communities of color and persons of lower socioeconomic status. These individuals experienced increased enforcement of new laws. We have yet to undo the damage that the framework of framing it as a moral depravity did for the understanding of and treatment for substance use disorder. So just a little bit of information about the total drug overdose death counts from the CDC provisional data. So some recent data just came out with data through March of 2022. The data I'm discussing here is data through December of 2021. So this looked at the overdose deaths in a 12-month period that ended in December of 2021. And during that 12-month time period through December 2021, 107,622 people died of a drug overdose. So this is the highest amount of overdose deaths on record for a 12-month period. Overall, it was a 15% increase in deaths compared with 2020. And about 2/3 of those deaths involved synthetic opioids. And when we say synthetic opioids, we're specifically referring to illicitly manufactured fentanyl and its analogs. And there were also significant deaths due to methamphetamine use. So when we think about overdose deaths, it's important to understand that they are not equal across genders and not equal across racial and ethnic groups. So this slide is looking at disparities by sex and race and ethnicity in death rates due to opioid overdoses among adults 55 years and older. And we're looking at the time periods from 1999 through 2019. So this is pre-pandemic. On the left-hand side is looking at the rates of opioid overdose deaths per 100,000 in persons 55 years and older during that time period. It is not breaking it down by gender or race and ethnicity. But what you can see is that there's a continually increasing trajectory of those overdose deaths between about the year 2000 through 2019. On the right-hand side is taking that same data, but breaking it down by gender and race and ethnicity. And what is most striking in this graph on the right-hand side is the line that has the very, very steep slope going upwards. And that is representative of non-Hispanic Black males. And so what that means is that among African-American males over the age of 55, their death rate due to overdose is much, much higher than any other racial ethnic group and higher than the female gender. This data is looking at overdose rates, again, by race ethnicity. And on the left-hand side is looking at United States data, and it's from 1999 to 2020, and it's separating out white non-Hispanic versus Black non-Hispanic versus Hispanic. And so again, what you'll notice is in the line with the squares, which represents the African-American or Black non-Hispanic population, that slope of that line has increased more significantly than the slopes in the other lines. And it has surpassed the line for white non-Hispanic persons. On the right-hand side is using age-adjusted opioid-involved mortality data per 100,000 population. Again, this one looking from 1999 to 2019. This is not breaking it up by gender. This is showing it just by race and ethnicity. And again, what is most notable is that significant increase in deaths in the African-American population represented by the red-colored line. So this study was looking at the evaluation of increases in drug overdose mortality rates in the United States by race and ethnicity before and during the COVID-19 pandemic. So this is pretty dense data, and I recognize that the graph on the left-hand side is a little bit challenging to read. So again, this is looking at pre-pandemic versus during the pandemic data. So I'm going to focus on some of the highlights from this study. So overdose death rates per 100,000 among Black individuals increased 16.3% in the time period from 1919 to 2020. So it was more significant than the rate for white individuals in 2020. So the overall 2020 overdose mortality rate among Black individuals was higher than that among white individuals for the first time since 1999. This is also a reversal of the overdose mortality gap among Black and white individuals that was noted in 2010. So these shifts reflect that Black communities have experienced higher annual percentage increases in overdose deaths compared with their white counterparts each year since 2012. In 2020, Black individuals had the largest percentage increase in overdose mortality, 48.8%, compared with white individuals, 26.3%. Interestingly, because I think this is far less publicized than the rates are for African Americans, the results also showed that American Indian or Alaskan Native individuals experienced the highest rate of overdose mortality in 2020. So it was 30.8% higher than that for white individuals. Drug overdose rates among Hispanic or Latino individuals remain the lowest among the groups assessed throughout the study period. However, Hispanic or Latino individuals also experienced a large percentage increase in drug overdose rates in 2020, and that was an increase of 40.1%. So overall, the pandemic had an effect in all racial and ethnic groups of increased overdoses. However, it disproportionately affected American Indian, Alaska Natives, and African Americans more than it did other racial ethnic groups. So this is from the MMWR, or the Morbidity and Mortality Weekly Report from the CDC. And this looked at drug overdose deaths by selected sociodemographic and social determinants of health characteristics. It looked at 25 states and the District of Columbia in 2019 to 2020. So on the left-hand side, if we look at the graphic, what it shows is the overdose death rate per 100,000 people comparing 2019 to 2020. So that rate went up the highest in the African American group at a rate of overdose deaths of 27 per 100,000 people to a rate of 39 per 100,000 people. Next, in the American Indian Alaska Native group, that overdose death rate went from 26 per 100,000 to 36 per 100,000, followed by less significant increases in the white population, an increase of 25 per 100,000 to 31 per 100,000, and then in the Latino group or the Hispanic group of 17 per 100,000 to 21 per 100,000, and the overdose rate remained flat for the Asian Pacific Islander non-Hispanic group. So the conclusion of this study was, in just 1 year from 2019 to 2020, overdose death rates increased 44% for African Americans and 39% for American Indians, Alaskan Native peoples. And really what they concluded was that there are variabilities within each community, which cannot be ignored. And it's really important that our community-based prevention and response efforts incorporate proven, culturally responsive actions that address disparities in overdose deaths and the inequities that contribute to them. So some of the suggestions that they made were increasing access to proven treatment for all people who have substance use disorder. So for people with opioid use and or opioid use disorder, or who experience exposure to opioids unintentionally through other substance use, MOUD is a critical part of that effort to decrease overdose risk. Harm reduction services can further reduce overdoses and save lives, and so we want to be sure to get in the hands of people who are using naloxone, fentanyl test strips, referral to substance use disorder treatment and MOUD if the person is receptive to that, accessing them to syringe service programs, etc. So this is also looking at that same MMWR article, so looking at drug overdose deaths, again, by race, ethnicity, and sociodemographic and social determinants of health characteristics. On the left-hand side is just showing in bar graph format the similar data that I showed from the previous page, but it's also looking at income inequality ratios and looking at the death overdoses. So in those, for instance, who had the different income within a race ethnicity, then there's differential in looking at those overdose rates. On the right-hand side, if we look about capacity for treatment, again, we see a disparity across populations. So in some of the areas with the highest provider capacity, you're not seeing that matched with the population that needs that treatment the most. This is an article that looked at epidemiological trends in opioid-only and opioid polysubstance-related death rates among American Indian and Alaska Native populations from 1999 to 2019. And this was a retrospective longitudinal ecological study. So this is very interesting because what it's looking at is substance use that's only related to opioids, or it's related to opioids and polysubstance use. And what they found is that many individuals are experimenting with polysubstance use. And so on the right-hand side, it's looking at the combinations that individuals are using, whether it's opioids and alcohol, opioids and benzodiazepines, opioids and cocaine, opioids and methamphetamine. And those patterns differ not only by gender, but also by location. So again, it's important to know what your patient population is using, and that's going to vary by the population itself, meaning what their race ethnicity is, what their location is, geographically speaking, what their gender is, what their age is, and also within subpopulations, it's going to be different, for example, between different American Indian, Alaska Native populations. So what individuals are doing in Alaska may differ from what individuals are doing in South Dakota to what individuals are doing in upstate New York. So it's important to create culturally responsive interventions. So it's important, in other words, to know your population, and you must know your population by engaging with your patient population and probably doing focus groups to help understand what's going on in your community. This was looking at trends in drug overdose deaths among US adolescents, and this study was from January 2010 to June of 2021. So it did include data from the pandemic. On the left-hand side is looking at overdose mortality among adolescents by substance type. As you can see, similar to adults, the most significant number of deaths are due to illicit fentanyls and synthetics. What that is referring to is illicitly manufactured fentanyl and its analogs. And on the right-hand side, it's taking that overdose mortality data among adolescents and it's breaking it up by race, ethnicity. And here you can see that, again, the most significant mortality rates are among American Indian or Alaskan Native adolescents. So this is a very interesting study that was looking at provisional drug combinations involved in fatal overdoses in US jurisdictions with detailed medical examiner data, and this is 2020 data. The reason I included this slide, it's not specific to race ethnicity, but it's showing you the different geographical patterns of polysubstance use. And so again, depending on what it looks like in your community, your harm reduction efforts and your overdose intervention and prevention messaging would be different. So just to take a few examples here, if we look at Los Angeles County, there's a large intersection between the substances fentanyl and cocaine. So perhaps in that community, they would be particularly, it's more for methamphetamine than cocaine even. So there is a wide interplay between cocaine and fentanyl in Los Angeles County, but it's far more common to find fentanyl with methamphetamine use. And then if we look at a different community, let's say the community of Connecticut, we can see here that fentanyl really is the predominant concern, and no matter what you're using, it pretty much appears to have fentanyl in it. If we look at another community, such as the Dallas-Fort Worth metro area, there's a very little intersection between fentanyl and other substances. So again, it's informative to know your local medical examiner data so that, again, you can target efforts towards your individualized community. So this is looking at overdose deaths by race ethnicity in the United States in the time period 2014 to 2020. What's most notable is the graphic on the right-hand side, which is showing you the percentage change from 2014 to 2020. So in the non-Hispanic white population, that increase went up by 65%. In the Hispanic or Latinx community, it went up by 192%. However, in the African American or non-Hispanic Black population, the increase in percentage of overdose deaths between 2014 and 2020 went up 243%. This study is looking at New York State Department of Health data. So this is coming from the Opioid Prevention Program Data to Action. This is looking at overdose deaths involving methamphetamine with and without fentanyl in New York State, outside of New York City, in the years 2016 to 2020, and it's looking at demographic data on race and ethnicity. So what is it showing us? So it's showing us the average annual crude rates of overdose deaths. Again, this is methamphetamine with and without fentanyl. And what I would like you to notice here is that the overdose death rates were highest among those aged 25 to 44 years old. And you can see that that death rate of 3.2 per 100,000 far exceeds other age groups, in which the death rates were 0.6 in the 15 to 24-year-old age group and 0.7 in the 45 plus age group. And the death rate for males exceeds that for females. So it was 1.6 per 100,000 in males compared to 0.7 in females. And then the death rate was higher in white non-Hispanic individuals at 1.4 per 100,000 compared to other racial ethnic groups. This data is looking at New York City data. And so this is showing disparities in New York City overdose deaths by race, ethnicity, age range, and neighborhood poverty. And this data is from 2019 and 2020. So on the left-hand side is looking at changes in rates of drug overdose deaths. So this is looking at rates per 100,000 residents in the years 2019 to 2020. So there were large increases in the rates of overdose deaths among Black New Yorkers. So this mirrors both New York State data and national data. Those aged 35 to 54 and residents of very high poverty neighborhoods. On the right-hand side is more information on those poverty rates. So if we look at very high poverty neighborhoods, they have a higher burden of overdose. So if you look on the left-hand side, you can see that the overdose fatality rates in very high poverty neighborhoods were far higher, more than double the rates in low poverty neighborhoods. So a rate of 48.2 compared to 18.4. And residents of very high poverty neighborhoods account for nearly 1 of 3 overdose deaths among New York City residents. Continuing with New York City overdose status, so this is looking at gender, race, ethnicity, age, and neighborhood, and this is 2020 data. On the left-hand side is looking at number of unintentional drug poisoning or overdose deaths by demographics, and again, from 2020. So we can see that deaths in males exceeded those in females. Deaths were highest in white individuals, but again, per proportion of population, deaths were highest in African Americans. And the age group 35 to 54 had the highest death rate. Then if we look at disparities in the geographic distribution of overdose, you can see that poorer neighborhoods have much higher doses, much higher rates of overdose than do more socioeconomically advantaged neighborhoods. So if we compare overdose rates in Hunts Point, Mott Haven, which was the highest at 75.3 per 100,000, that was greater than 2.5 times higher than the New York City rate overall, which was 30.5 per 100,000, and greater than 13.9 times the neighborhood with the lowest rate, which was Greenwich Village, Soho, with a rate of 5.4 per 100,000. I also want to point out that most of those highest poverty neighborhoods with the highest overdose rates are in the Bronx, and some of them are in Harlem or Washington Heights. Continuing with New York City overdose death rates by race ethnicity, this is looking at data from 2020. On the left-hand side is showing us that in 2020, Black or African-American New Yorkers had the highest rate of overdose death and the largest absolute increase in rate from 2019 to 2020. So from 2019 to 2020, it was an increase of 14.2 per 100,000. So it had the highest rate overall at 38.2 per 100,000. On the right-hand side is looking at the rate of overdose death among New Yorkers of a Latinx heritage. But again, not everyone within that designation has equal overdose rates. So there are disparities within the Latinx identity. And so what they found was that Puerto Rican heritage had a much higher overdose death rate among Latinx New Yorkers. So they compared to, for example, Dominicans, those of Central and South American heritage, Mexican heritage individuals, and then other Latinx individuals. And you can see that the rate of overdose death among Puerto Ricans was considerably higher, almost 3 times as high as the next highest overdose death rate that was in Dominicans. This is looking at unintentional overdose deaths in New York City through Q2 of 2021 by borough of residence. And here again, you can see that the Bronx leads in overdose deaths, followed by Brooklyn, Manhattan, Queens, and then Staten Island. And if we break it down to neighborhoods, then we can see that multiple neighborhoods in the Bronx, as well as neighborhoods in Harlem, have the highest rates of overdose death in New York City. So now we're going to talk about the historical and current legal framework regarding substance use in the US that has been grounded in racism. So first, let's talk about the development of a racist legal framework to restrict substance use. So there's a very racist image on the left-hand side that actually was published in the New York Times and was written by a physician, unfortunately. So just to highlight some of the legislation that passed, in 1882 passed the Chinese Exclusion Act. The opium was associated with Chinese immigrants, and the act was an attempt to get rid of opium dens, but really was an attack on Chinese individuals. In 1909, opium smoking was outlawed, again, related to use by Chinese immigrants. So it was intended to punish Chinese immigrants specifically. In 1914, the Harrison Act that I mentioned previously was passed and led to the end of a physician's ability to treat opioid use disorder with opioids. From 1920 to 1933 was prohibition, and this was the constitutional ban of alcoholic beverages. And in 1937 passed the marijuana tax law, which was directed at use by Mexican immigrants. So a little bit more about the concept of, quote, drugs and crime, unquote, and more about prohibition in the Harrison Act. So prohibition was not just about alcohol use. The government and the press propagated fears of a, quote, depraved, drug-crazed, unquote, lower socioeconomic class, particularly among African Americans and whites. And this helped drive support for prohibition. African American males were purported to be mixing cocaine and alcohol and other drugs and committing crimes, quote, under the influence, unquote. The Harrison Act regulated and taxed the production, importation, and distribution of opiates, so these were derivatives of opium, and coca or cocaine products, which had previously been completely unregulated. So more on cocaine and African Americans and racist beliefs in the South. In the South, people believe that Reconstruction, the period that followed the Civil War, was responsible for widespread criminal behavior by African Americans. Cocaine was thought to be responsible for unleashing the, quote, primitive sex drive, unquote, of the, quote, Negro, unquote. In other words, the rape of white women was the, quote, inevitable horrid result, unquote. And this led to the lynching of African American men. So this was all created in the press. The New York Times headline on February 8th of 1914 read, "Negro cocaine fiends are a new menace." And this was from the article. This was written by the same physician who created the racist graphic a few slides back. Quote, "Murder and insanity is increasing among lower class Blacks because they have taken to sniffing since deprived of whiskey by prohibition," unquote. And that's from the infamous Edward Huntington Williams, MD. So how did this racist legal framework get developed? So I would be remiss if I did not talk about Harry J. Anslinger, who is considered the father of the war on drugs in the United States and abroad. He was the first commissioner, and his tenure was from 1930 to 1962. So he oversaw more than 3 decades of policy. He was the first commissioner of the U.S. Treasury Department's Federal Bureau of Narcotics. He was a supporter of prohibition, the criminalization of drugs, and cannabis prohibition. After serving as the commissioner of the Treasury Department's Federal Bureau of Narcotics, he served 2 years as U.S. representative to the United Nations Narcotics Commission, exporting his racist ideas internationally and affecting worldwide drug policy. He was widely regarded as a racist and a white supremacist who used his power and the policies of his office to attack minoritized communities, and especially minoritized individuals who became public figures. He created the Campaign Against Marijuana, which lasted from 1930 to 1937. He falsified data and lied to Congress. He penned racist propaganda such as, quote, "Reefer makes darkies think they are as good as white men," unquote. He targeted minoritized communities, particularly African Americans, especially jazz musicians, with drug charges and harassment. Billie Holiday is an example of an individual who was targeted by him. This was part of his strategy to justify the existence and budget of the Federal Bureau of Narcotics, which he was the commissioner of for more than 3 decades. He suppressed and condemned scientific data that did not support his viewpoint, including the report in 1939 by the LaGuardia Committee on Marijuana Use and the jointly penned ABA-AMA Joint Report on Narcotic Addiction in 1958 that condemned the criminalization of substance use disorder. Moving forward in time, in 1971, President Nixon declared a war on drugs. It was a war fought by the police and the courts, and the very intentional casualties of this war were African American males. In 1973, the Rockefeller drug laws were passed in New York State. The penalty for selling 2 ounces of any illicit drug or possessing 4 ounces of any illicit drug was 15 years to life in New York State. It became the most severe drug law in the United States, and many other states followed suit. So sadly, we learned a lot more about the Nixon drug war when in 1992, journalist and author Dan Baum interviewed John Ehrlichman, who was Nixon's counsel, and he was his assistant during the Nixon presidency. So for his book, Dan Baum's book, called Smoke and Mirrors, The War on Drugs and the Politics of the Future, he interviewed Mr. Ehrlichman. And he asked Mr. Ehrlichman, why the war on drug users? And here is the quote from Mr. Ehrlichman. Quote, "You want to know what this was really all about? Nixon had 2 enemies, the anti-war left and Black people. We knew we couldn't make it illegal to be either against the war or Black. But by getting the public to associate the hippies with marijuana and Blacks with heroin and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did," unquote. I think that quote speaks for itself. So moving forward to 1986 was passed the Anti-Drug Abuse Act, passed by Congress in 1986. It changed the federal system of supervised release from a rehabilitative system into a punitive system. It enacted new mandatory minimum sentences for drugs, including marijuana. It was prompted by the deaths of Len Bias and Don Rogers, both due to cocaine use and the emergence of crack cocaine. It created unequal penalties for crack cocaine possession and powder cocaine possession. Minimum sentence of 5 years without the possibility of parole for 5 grams of crack cocaine, and the same penalty for 500 grams of powder cocaine. So it created a 100-to-1 disparity, which had clear repercussions along racial lines. By 1987, 72% of the cocaine arrests in New York City were for crack, and that was primarily among brown and Black people. So crack became the next chapter in the drug war. So from George Santayana, quote, "Those who do not learn history are doomed to repeat it," unquote. The emergence of crack cocaine use reanimated the perceived association between crime, drug use, and African Americans. In 1988, the CDC cited crack-related sex work as a major factor responsible for sexually transmitted infection in HIV incidence and prevalence. And this led to shaming and blaming of African Americans. Next, I want to talk about incarceration in the US historically and currently. So these are some images related to the war on drugs. So on the left-hand side, death to crack dealers, and on the right-hand side, whatever they do, I'm her comfort, I'm her protector, how the foster system has become ground zero for the US drug war. So let's talk about unequal sentencing and drug offenses and incarceration. So first, on the left-hand side is a quote from the Institute of Medicine from 1996. Quote, "The US Sentencing Commission reported in 1995 that whites account for 52% of all crack users and African Americans 38%. However, 88% of those sentenced for crack offenses are African American and just 4.1% are white," unquote. And from the Sentencing Project, 50% of the inmates in federal prisons are serving time for drug offense. The number of people in state prisons for drug offenses today is 10 times greater than in 1980. So in 1980, there were 40,900 individuals in prison, and in 2016, it was 450,345 in prison for drug offenses. The average time served in federal prison for a drug offense in 1986 was 22 months, and in 2004, 62 months. So looking at incarceration for drug offenses by race, ethnicity, we also see many disparities. On the left-hand side is looking at the US population in 2012, which was 72% white, 14% Black, and 16% Hispanic or Latinx. However, if we look at people in state prison for drug offenses in 2012, we see that 43% are Black, and 35% are white, and 22% are Hispanic or Latinx. This is looking at incarcerated Americans between 1920 and 2007. And so it has noted where the war on drugs was declared on the graph by Richard Nixon, and that was in 1971. And you can see the precipitous increase in incarcerated Americans since that time. This is looking at change in prison population and incarceration rate between 1910 and the year 2000. So on the left-hand side is looking at the change in prison population each decade, 1910 to 2000. And so you can see in 1970 to 1980, there were 119,545 persons incarcerated. Between 1980 and 1990, there were 424,006 individuals, and between 1990 and 2000, 532,448. And if we look at the change in incarceration rate from 1910 to 2000, you can see again it starts to rise after 1971 when the war on drugs was declared, and it has increased from the time of 1970, a rate of 166.3 to a rate of 703. So 7 times the rate that it was. So this was a document that came out called The Race to Incarcerate, and I'm going to point out some key points in that document. So in 1997, even though African Americans made up only 13% of the population, half of the 1.2 million state and federal prisoners were African American, for a total of 548,900. African Americans are imprisoned at 6.6 times the rates of whites, so 3,253 versus 591 per 100,000. 1 in 3 Black men between the ages of 20 and 29 were under some form of criminal justice control in prison, jail, or on parole or probation in 1995. Other studies have shown that half the young men in Washington, D.C., and more than half the young men in Baltimore are under criminal justice control. So a Black male born in 1991 stood a 29% chance of being imprisoned at some point in his life, compared to 4% for a white male born that same year. 1.4 million African American men, or 13% of the Black adult male population, have lost the right to vote due to their involvement in the criminal justice system. In the states with the most restrictive voting laws, 40% of African American men are likely to be permanently disenfranchised. This is looking at disparities in incarceration rates, lifetime likelihood of imprisonment, and this comes from the prevalence of imprisonment in the US population, 1974 to 2001, and it was published in 2003. So first, all the way up at the top on the left, we have the likelihood of imprisonment among all men. So that rate is 1 in 9. If we look at that rate among white men, it becomes 1 in 17. If we look at that rate in Black men, it becomes 1 in 3. If we look at that rate in Latinx men, it becomes 1 in 6. If we look at the rate among all women, it is 1 in 56. If we look at that rate among white women, it's 1 in 111. If we look at that rate in Black women, it is 1 in 18. And if we look at that rate in Latinx women, it is 1 in 45. Next, I'm going to discuss current opioid epidemic and opioid use disorder in the United States, including treatment disparities. So first, let's look at the depictions of opioid use disorder and how that differs by race ethnicity. So if we talk about a Black and brown population versus a white population, there's a difference in narratives. Before the white population started overdosing in the more recent opioid epidemic, and there became a change in the narrative, really how we described opioid use disorder and opioid overdose deaths, it was more a criminal justice issue. It involved incarceration. It was considered a moral failing, and we talked about the war on drugs. However, the narrative changed when it became obvious that there were more white overdose deaths occurring than had been previously. And the narrative changed to a public health issue, a focus on treatment, emphasis on it as a medical condition, and just an overall kinder, gentler approach. So what is the new face of addiction like? As the number of white people using prescription opioids increased, policy evolved. Instead of focusing on criminal sanctions, there became a focus on treatment for substance use disorder. Media portrayals focused on blamelessness and tragedy, and there were divisions in treatment, with white patients more likely to get buprenorphine and African American patients more likely to get methadone. So what did that changing framework of substance use disorder look like? So as I mentioned, substance use now became framed as a disease of the brain or a chronic medical condition, not a moral failing or a crime. That is a great trend overall, and that is how it should be framed. But it's unfortunate that it became framed that way once it started affecting more white people. New treatments and technologies emerged to support people who use drugs. There became misuse deterrent formulations. There was an easing of the criminal justice system, leaning towards treatment and a focus on treatment for individuals with SUD and alternatives to incarceration. Again, that is a great thing. but we're talking about why it occurred. We also got the Data 2000 waiver, so allowing for more anonymity in treatment with buprenorphine being prescribed in office-based practicing. You also began to see direct marketing to consumers, and media campaigns regarded the opioid epidemic as primarily featuring white faces and white victims, quote unquote. We also saw technologies of whiteness. So you saw the neuroscience of addiction, new biotechnologies, change in regulatory structures, and direct marketing to white people. So that new face of addiction was white. And so here's an example of a newspaper article. So Hooked, a teacher's addiction and the new face of heroin. And here's some advertising for medication for opioid use disorder. So on the left-hand side is an advertisement for buprenorphine, and on the right-hand side, an advertisement for extended release naltrexone. Geography also became a proxy for race. There was more buprenorphine treatment available in high-income white neighborhoods and more methadone available in populations that were Black and brown and lower-income neighborhoods. And you can see that represented here in a map of New York City in 2007 with buprenorphine prescriptions by zip code on the left-hand side, so primarily in Manhattan, Staten Island, some parts of Brooklyn, versus methadone availability primarily in Upper Manhattan, the Bronx, Brooklyn, in contrast to the map on the left. So when we look at buprenorphine treatment divide, we do see that it is divided by race, ethnicity, and payment source. So between 2004 and 2015, the number of buprenorphine visits rose from 0.04% to 0.36% of all ambulatory visits. So it represented 13.4 million visits between 2012 and 2015. From 2012 to 2015, a buprenorphine prescription was received at considerably more visits by white patients than for patients of other races and ethnicities. So 12.7 prescriptions for white patients versus 363 prescriptions for patients of other races and ethnicities. The number of buprenorphine visits by self-pay patients dramatically increased from almost 586,000 in 2004 to 5.3 million visits in 2012 to 15. So it accounted for almost 40% of the visits. So the conclusion of this study was, quote, after accounting for a payment method, sex, and age, we found that Black patients had significantly lower odds of receiving a buprenorphine prescription at their visit, unquote. This study was looking at access to office-based buprenorphine in areas with high rates of opioid-related mortality. And so it was looking at cash-paying patients versus Medicaid recipients. The setting for this study was 6 U.S. jurisdictions that all had a high burden of opioid-related overdoses. They looked specifically at Massachusetts, Maryland, New Hampshire, West Virginia, Ohio, and Washington, D.C. They did what's called a secret shopper study, so they pretended to be patients. So what they did was between July and November 2018, they contacted almost 550 publicly listed buprenorphine prescribers twice, posing as an uninsured client or a Medicaid-covered patient, all who were seeking buprenorphine treatment. So what were the results of this secret shopper study? So new appointments were offered to 54% of the Medicaid contacts and 62% of the uninsured self-pay contacts. And whereas 27% of Medicaid and 41% of uninsured self-pay contacts were offered an appointment with the possibility of buprenorphine prescription on the first visit. So what were the conclusions of this study? That many buprenorphine prescribers did not offer new appointments or rapid access to buprenorphine to callers reporting active use, particularly if they were not paying cash and instead had Medicaid. This study was looking at buprenorphine treatment by both payment source and by race ethnicity. And what they found on the left-hand side was that if you were white, you were far more likely to get a prescription for buprenorphine and a visit for buprenorphine compared to African Americans and other races and ethnicities. And if you were self-pay, you had the highest likelihood of getting an appointment and a buprenorphine prescription. And following that, you were likely to get it if you had private insurance, and less likely if you had Medicare or Medicaid. And then there was an other category, and I'm not sure what qualified the other category. So this study is looking at widening racial disparities in buprenorphine treatment. So this looked at population-weighted rates of buprenorphine distribution in Medicaid expansion states from 2007 to 2017. And what they found was that the more white residents you had in your zip code, the more likely you are to have buprenorphine prescriptions in your zip code. The less white your zip code was, the less likely there were buprenorphine prescriptions in your zip code. This study was specifically looking at barriers to treatment for pregnant persons. And I know this is a very busy slide, and the graphics, the details are quite small. The point of this study was showing that, and this was in Massachusetts specifically, that if you were pregnant, you were less likely overall to get a buprenorphine prescription or a methadone referral than if you were not pregnant. And among pregnant persons, if you were a white pregnant person, you were more likely to be referred to an OTP or to be prescribed buprenorphine than if you were a Black pregnant person or a Hispanic or Latinx pregnant person. So this study was looking at trends in buprenorphine treatment disparities during the COVID-19 pandemic in Massachusetts. So this was a cross-sectional study, and they used data comparing 12 months before and after essentially shutdown in March of 2020 in Massachusetts. And they were comparing access to treatment with buprenorphine. So what did they find out? So among over 4,500 patients that were seen in the period before the COVID-19 emergency declaration in March of 2020, almost 60% received buprenorphine. Among the 3,600-ish patients that were seen in the second time period, so after lockdown for COVID, 55% received buprenorphine. So not too much of far fewer patients were seen overall, but the percentage was almost the same for who received buprenorphine. But what did they find about differences about who received buprenorphine? So what they found was that younger patients, less than 24 years old, had a lower likelihood of receiving buprenorphine in either time period. Male patients had a greater likelihood of receiving buprenorphine compared to female patients in both periods. And racial disparities emerged in the time period following lockdown for the COVID-19 pandemic, with non-Hispanic Black patients or African Americans having a lower likelihood of receiving buprenorphine compared to non-Hispanic white patients. So their conclusions were, following the onset of the COVID-19 pandemic in Massachusetts, ongoing racial, age, and gender disparities were evident in buprenorphine treatment, particularly with younger Black and female patients less likely to be treated with buprenorphine across an integrated healthcare system. This is looking at data around urine toxicology testing by race. And what you find here is, regardless of your time in treatment, whether it's 1 month, 3 months, or 6 months, if you are African American or Black, you're more likely to be tested with urine toxicology than you are if you're white. And this is looking at inequitable prescribing of opioids and naloxone by race and ethnicity. So on the left-hand side, I'm going to focus on the conclusions of this study. It was looking at an assessment of racial, ethnic, and income disparities in the prescription of opioids and other controlled medications in California. And so what they saw was across drug categories, controlled medications were much more likely to be prescribed to individuals living in majority white areas. These discrepancies may have shielded non-white communities from the brunt of the prescription opioid epidemic, but also represent disparities in treatment and access to all medications. So, quote, the prescription drug crisis should really be thought of as a double-sided epidemic, unquote. And that was a statement from the study's lead author, who was a medical student at that time during the study at the David Geffen School of Medicine at UCLA. The second part of his quote is, essentially, the systematic racism within the healthcare system has led to increased addiction and overdoses in low-income white areas, but also to insufficient treatment among communities of color. And per another physician who participated in the study, quote, if you're living in Compton, you're probably not getting a lot of prescribed opioids, unquote. And Compton is a heavily African-American neighborhood in LA. And the second part of his quote is, you can't tell me there are no prescriptions for opioids, so to speak, in Compton because no one is in pain in Compton. It just defies logic. On the right-hand side is looking at inequitable prescribing of opioids and naloxone by race, ethnicity. And so what they found in this study was that naloxone prescriptions varied by patient race, ethnicity, and by health condition. And what they found was even if individuals from different race ethnicities were prescribed opioids for a variety of medical conditions, that people of color, even if they had something like a bone fracture, were less likely to receive opioid prescriptions than were their white counterparts. And if they were prescribed opioids, they were less likely to be prescribed naloxone than were their white counterparts. Next, we're going to talk about institutional and systemic racism, historical trauma, and stigma. So first, let's talk a little bit about institutional and structural racism. So there are system-level factors, including health and community policies and organizational practices that lead to and perpetuate ongoing health inequalities. Also, there's a role that implicit bias, interpersonal racism, and microaggressions play, again, in perpetuating health inequalities. So again, there's a shift in focus from race of the patient to racism faced by the patient. That's how we should be thinking about it, instead of what's wrong with you to what happened to you. So when we think about 4 levels of racism, then we can think about a personal level. So these are private beliefs and prejudices and ideas that individuals have. An interpersonal level, the expression of racism between individuals. An institutional level, discriminatory treatment, policies, and practices within organizations and institutions. And then a structural level, system in which public policies, institutional practices, and other norms perpetuate racial group inequality. So this is a very busy slide, but this is to help understand historical trauma. And the example here is of Indigenous persons or Alaskan Natives. So on the right-hand side is the cycle of historical trauma. So this is starting with a history of trauma and historical trauma, which leads to a traumatic stress reaction, including grief and other strong and emotional or physical reactions. This leads to increased risk of substance use. They have the old language there, I apologize, but it's basically referring to increased risk of substance use and or substance use disorder, increased vulnerability of suicidality and mental health diagnoses such as PTSD, anxiety, and depression. And this leads to increased risk of experiencing other traumas such as accidents, violence, physical and sexual abuse, which then leads into more trauma, et cetera. And it's a cycle which perpetuates itself. Looking on the left-hand side, it's looking again at the many different levels of historical trauma that can occur. So there's trauma on the nation level. So this is political disempowerment, loss of collective identity, and genocide. There's loss on the community level, loss of whole generations of children, such as when they were sent away to the sponsored schools where they try to remove their Indigenous collective identity. It includes negative labeling and stereotyping of community, and that can lead to community disorganization, conflict, and social problems. It occurs on the family level, the loss of children, grief, anger, and helplessness, and that can lead to family dysfunction, domestic violence, and abuse. It can occur on the individual level, so forced separation from parents, denigration of identity, suppression of culture, physical and sexual abuse. All that can lead to low self-esteem, mental health diagnoses, difficulty parenting, more low self-esteem, more mental health diagnoses, and difficulty parenting, etc. So how could that manifest in the next generation? It can lead to epigenetic changes. So these are not changes in your genetic code, but these are how the environment plays on how your genetics are expressed. And so that can be different in every individual who experiences it, but it can change the balance of neurotransmitters in the brain and actually change neural circuits in the brain and cause a persistent stress response, which plays out in myriad fashion. So just to remind us about stigma, so stigma is the largest obstacle to medication treatment for opioid use disorder. And stigma is based on, quote, philosophical, unquote, bias and erroneous beliefs about the medication. And that came from an article published in 2017. So let's remind ourselves of the types of stigma. There's public stigma, negative attitudes and fears that isolate those with addiction, structural stigma, excluding those with addiction from opportunities and resources, and internalized stigma, so believing negative stereotypes about oneself. Some common examples of stigma include the following. If you have to take a medication, it's not real recovery. You are just replacing one drug with another. How long do people have to take medication for treatment? People taking medication can't function normally. People taking medication can't take care of their children. What are ways to reduce stigma? Acknowledge your own feelings. Do not prejudge people. Listen, empathize, and leave opportunities for re-engagement. So how do we address stigma? How do we create a safe space for individuals? And how do we utilize trauma-informed care? So when we think about creating a safe space, we want to think about sharing with somebody so that it's equal power in that relationship. We do not want to have power over individuals. So what can we do to promote that safe space? We can think about our organizational context, practicing democracy in our setting, physically creating a safe space, equal representation, challenging stigma, and taking measures to address socioeconomic inequities. And how do we apply trauma-informed care within our practice? It occurs in our interactions directly with our clients. It occurs in our service cultures, in our interagency and intersectoral collaboration, and it influences social conditions. So creating the need for trauma-informed practice across society. So what do we need? We need an anti-racist approach. So opioid-related deaths in white communities are unfortunate and they are devastating. But continuing to elevate the pain of those communities over other races and ethnicities will only worsen health disparities and jeopardize further the lives of people of color. So the US really requires an anti-racist agenda to truly ensure progress and improve health outcomes for everyone. The Chicago Urban League issued a brief entitled Whitewashed, the African American Opioid Epidemic, which highlighted 3 principles to guide opioid policy to ensure Black communities are not left behind. Black voices cannot be excluded from the opioid narrative. Black leaders and organizations must be involved in all stages of public health policy development and implementation, and health programs must meet the needs of Black communities, including removing current and historic barriers to health. They continued by recommending the following. expanded access to addiction treatment in Black communities and other historically oppressed groups, increasing funding for treatment and wraparound services for all substance use disorders, not just opioids. Opioids are not always the leading problem. Opioids are responsible for a staggering 91% of drug overdose deaths in New Hampshire, but only 26% in Hawaii, and that was 2017 data. National numbers show methamphetamine-related hospitalizations, and now overdose deaths are soaring. Racial impact statements for addiction treatment, services, prevention, and enforcement policy, similar to those in some states for sentencing, parole, or probation policy. Increased opportunities for faith-based organizations to provide prevention services, treatment, and recovery services, as well as harm reduction services. In addition to culturally competent, or I would say culturally responsive, substance use disorder services and treatment programs, an anti-racist framework to specifically address the needs of people of color seeking services within a health system and society where structural racism exists. So what can you do as a healthcare provider to combat disparities in overdoses and access to treatment? So with respect to the increases in disparities in US drug overdose deaths by race and ethnicity, we have opportunities as clinicians and as healthcare systems. We need to raise awareness about overdose disparities and take action to remedy disparities and access to medications for opioid use disorder, harm reduction services, and overdose prevention strategies. So what does that mean? It means creating culturally competent or culturally responsive care, being aware of our biases, and non-judgmental communication. And that will help people to access care more easily, and it will break down barriers such as stigma and mistrust in healthcare systems. Integrate substance use disorder treatment and harm reduction services into routine clinical care, including in emergency departments and inpatient hospital care. Implement innovative service delivery models. So this includes maintaining telehealth and remote initiation of medications for opioid use disorder, co-locating health services with harm reduction services, linking and retaining persons with opioid use disorder and other substance use disorders in care. And why is that important? Because we know that the more that people are engaged in care and the lower threshold that care is, the better outcomes we will have, and the more that it will decrease someone's risk for a fatal overdose. Strengthen collaboration between healthcare systems, public safety, and public health. This requires creating a holistic community response to overdose prevention that's cooperative within sectors. Acknowledge that disparities in overdose deaths are exacerbated by underlying social determinants of health, structural racism, and historical trauma that contribute to increased risk for multiple health-related outcomes, including substance use and overdose, and can serve as substantial barriers to life-saving care. And it's important that we understand intersectionality and its role in identity, oppression, and privilege. The graphic here is an example of a person who has experienced oppression in many different roles that they have in their communities. So as a person of color, as a person with a disability, as a person who has reading or writing difficulties, as a person who's homeless, as a person who's a parent, as a person who's in the LGBTQIA+ community, as a person who's formerly incarcerated. So some conclusions before we wrap this up. So US drug policy and law enforcement have been racially biased historically, and reform is needed currently to undo disproportionate harms on minoritized communities. Attention in the current opioid epidemic and with respect to overdose deaths has not focused on African Americans or other minoritized communities. It is unconscionable that it took the deaths of white Americans to bring attention to and reframing of opioid use disorder and the opioid epidemic. Institutional and systemic racism, historical trauma, and stigma continue to hinder minoritized communities from accessing medications for opioid use disorder and overdose prevention. Cultural and religious beliefs and stigma within the minoritized communities itself may play a role in minoritized communities with opioid use disorder and/or mental health issues, self-identifying and seeking treatment or not with medication for opioid use disorder. Leadership within these communities must address this. We must be culturally humble, listen to our patients' concerns, fears, and stories, and adapt our approaches accordingly. Suspicion towards the medical system by African Americans and other minoritized communities, while well justified, may play a role in minoritized communities not seeking treatment with medications for opioid use disorder. If you have any questions, please feel free to email me at kelly.ramsey@oasis.newyork.gov. And I thank you so much for your attention, and I'll turn it back to Dean.
I want to thank Dr. Ramsey for today's program. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you've viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.